Now, instead of Dr. Akanksha Bhatia, I have the privilege of calling here Dr. Madhuri Patil, who will be deliberating on PCOS, body image disorder. Madam Madhuri Patil does not need any introduction. She is the brainchild, along with Dr. Durusha, for this conference, wonderful conference. Over to you, ma'am.
So I will talk on mood and anxiety disorders in women with PCOS, whether the incidence is much higher as compared to the other women. So basically, when we talk about mood disorders, we know that it is based on several diagnostic and statistical manuals. And we have to also look at the other depressive disorders wherein we look at, and we have to distinguish them from major depressive disorders, dysmic disorders, dysphoric mood dysregulation disorders, premenstrual dysphoric disorders, as well as depression, which is not otherwise specified. And we know that the prevalence of mood disorders is as high as 18%. If you look at this graph, this is basically the US, and we can see that the prevalence is quite high. But when we look at the age and the incidence of mood disorders, we can see that maximum of them is between the age of 18 years to 60 years. So once you're postmenopausal, your incidence of mood disorders reduces. And this was a paper which looked at the prevalence of depression in South India, and this paper was published from Chennai. And again, you can see that the incidence of depressive disorders is much higher in women as compared to the male population. And if you look at what are the screening recommendations, it is said that screening of depression in the general adult population, including pregnant and postpartum women, is required, and it should be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. But in India, probably it's not possible, because though the incidence wherein the people are going to the psychiatrist has increased, but still we do have a taboo, and many of us would not like to visit a psychiatrist, though today the psychologists still are playing a huge role, and many people do go to psychologists and take help from the psychologist. And then if you look at this paper, it was seen that the PCOS women had a higher positive screen, as well as the incidence was also higher as compared to the controls. And basically they presented with either fatigue, sleep disturbances, diminished interest, appetite changes, feeling down, feels like failure, difficulty in concentrating, psychomotor disturbances, and 12% also had suicidal thoughts. And in this meta-analysis, you can see that there is an increased incidence of depression score in women with PCOS as compared to the controls, and this is statistically significant with an odds ratio of 4. And of all the symptoms, it is the generalized anxiety disorders and major depressive disorders which are much more common. And this was a study which was published in one of the Indian journals, and this study came from Kashmir. And so we can see that it's not only the urbanization which leads to depressive disorders, but even in a place like Kashmir, which does not have much of urbanization, though they have their own problems, the incidence of depression is quite high. And this was the updated meta-analysis on the depressive symptoms in PCOS, and we can again see that the odds ratio is as high as 3, and therefore we can say that they are more common in PCOS as compared to the controls. And when we look at the moderate and severe depressive disorders, again, they are much more common, though the overall incidence has an odds ratio of 3, that for moderate and severe has an odds ratio of 4. And it was also seen that obese women have a higher incidence of depressive disorders as compared to those who have a lower BMI. And in this BMI control study, we can see that the weight really makes a difference. And if you take 2 women of the same weight or the same BMI, the incidence of depressive disorders is much higher in women with PCOS. So then what are the screening tools? So we have the patient health questionnaire, we have primary care evaluation of mental health disorders questionnaire, you have psychiatric neuropsychological interviews, we have a symptom checklist, depressive adjective checklist, we also have the Minnesota multiphasic personality inventory, and you have the Beck's depression inventory. And if you look at the longitudinal risk of depression, the overall prevalence is about 40%, and this increases over a time to more than 19%. And in this cohort study, which was a nationwide cohort study from China, you can see that the incidence of depressive disorders as well as anxiety disorders is much higher in women with PCOS, and this was statistically significant. So what should be the frequency of screening, or whether screening should be done in all PCOS women? And probably the question is yes, but we are not doing it. And usually, I mean, it's really, there are no studies which have been conducted which says at what time you must do the screening and or initiate the screening, and what should be the pragmatic approach to screen, whether we have to screen all patients or we should not screen all of them, and whether follow-up screening is essential. And I think it is essential, because what we need to look at is the comorbidities, the life events, as well as the family history. Coming to anxiety disorders, we know that we have to separate it from the mood and depressive disorders in the woman, PCOS woman, from anxiety disorders. And basically, what we have to look at is selective mutism, specific phobias, social anxiety disorders, panic disorders, panic attacks, agophobias, generalized anxiety disorders, and any substance medication-induced anxiety disorders. All those anxiety disorders which are due to another medical condition, other specified anxiety disorders, and unspecific anxiety disorders. So we can see, apart from anxiety disorders in the PCOS patient, there are so many differential diagnoses. So before labeling a PCOS woman that she has anxiety, depression, or mood disorders because of the PCOS itself, we have to eliminate these disorders in that woman. And you can see again, as compared to the mood and depressive disorders, again, the incidence of anxiety disorders in the PCOS woman is much higher in the reproductive age group as compared in the postmenopausal age group. And you can see that it is also much higher in the PCOS as compared to the controls. And the symptoms also are much more severe in the PCOS woman as compared to the controls. And when we look at the BMI control study, again, if you take two women of the same BMI, the incidence is much higher in the woman with PCOS. And again, the screening tools for anxiety are hospital anxiety and depression scale, brief scale for anxiety, Beck anxiety inventory, the Greek version of state trait anxiety inventory. Then you have the primary care evaluation of mental disorders, patient health questionnaire, neuropsychiatric interviews, and also the symptom checklist of the German version. Many patients do have coexisting mood as well as anxiety disorders, and basically there is, because of their image, basically what they have is a social phobia. They also can have specific phobias, panic disorders, and major depression, because there's a lot of body image disorder which we see in PCOS1, and this is much more common in the adolescent, and therefore probably they do require some form of psychological intervention. And if you look at the quality of life, we can see that the PCOS are more distressed as compared to the controls, and therefore every PCOS girl or a woman walking into your consulting, the first thing, instead of scaring her, what we need to do is to talk to her and tell her what are the problems related to the different issues of PCOS, and this will probably help us in reducing their psychological burden. Coming to the treatments, we have antidepressants, we have anti-anxiety medications. We also, the psychological counseling is the most important. Then we need to talk to them about the weight loss interventions, and Shilpa has very well described how the diet is going to help, and we are also going to see how the other lifestyle parameters are going to help. we could use hormonal contraception and metformin. And here we can see in this randomized controlled trials where they look at the preconception interventions like lifestyle modification, oral contraceptive pills, and combination of lifestyle and oral contraception pills before the patient goes for treatment of infertility. They found that the depressive disorders and the anxiety symptoms much lower in those women who were using oral contraceptives and as compared to lifestyle interventions. And if you look at this figure where they compared the combined with the lifestyle and with the OCPs, we can see that it is statistically significantly better outcome when you used both OCPs and lifestyle in these women who have psychological disorders like depression and mood disorders. Again, if you look at the adolescent, there was a better outcome when we used lifestyle plus OCPs as compared to OCPs alone plus metformin. And we know that diet, exercise, and if you compare everything, we can see both combined diet as well as exercise has a better outcome on the anxiety as well as depressive and mood disorders as compared to diet alone or exercise alone. Therefore, screening for depression and anxiety is very important, and at the first visit, if we find that there are risk factors, then it's best to refer them to specialists, and treatment of both mood disorders and PCOS symptoms is important. And I will also talk about the recent guidelines now, which are going to be published at the ESHRE meeting. So this is just what they recommended, is that the emotional well-being is the most important thing that we need to look at. And what were the recommendations? That depression and or anxiety should be routinely screened and assessed by all appropriately qualified health professionals in women with PCOS. Disordered eating, including eating disorders, negative body image, and psychosexual dysfunction should be considered in women with PCOS. And if a woman with PCOS is positive on screening, practitioners should further assess and appropriate management should be offered. And the range of simple tool should be identified and made available to screen and assess in clinical practice, because it's not possible for us to give complicated forms, which I don't think the PCOS women also or the adolescent girls would like to fill. So it should be as simple as possible. And the psychological counseling forms the first form of treatment when any woman with PCOS walks into your consultation. Thank you.
Thank you very much, madam, for the last minute's rescue and wonderful insights.